Well, good afternoon, everyone. So it's my distinct pleasure to introduce ToddParish to you guys today. Todd and I have had a close relationship for the past 5 years, doing some work that some stuff that I wanted to do up in Chicago with some criminal cases, which I'll get to in a second. By way of training, Todd started out as a biomedical engineer, his undergraduate master's at Case Western in that area, and then he worked at Siemens for a while, where we actually got to get into all the nitty-gritty of Siemens medical with respect to just learn. I think you learn a lot if you spend a little bit of time in industry about how the system works, how the things work, and how to fix things when you want to implement solutions on your scanners. And Todd then did his PhD at the University of Minnesota at the central, imaging place on the planet there. Nothing else to do, it's too cold, right?
Right. Helium,
And
don't use much helium.
and since, I guess, about the last 8-9 years, he's been the director of brain imaging and advanced MRI at the Northwestern University. So Todd has done a wide variety of different types of grants. He's actually had, and in this world, you have to diversify your portfolio to try to fund yourself. He's had money from Wrigley to study the impact of chewing gum on brain imaging. He's had money from to study acupuncture and the impact there versus different types of acupuncture. He has, when you look through his grant portfolio, it's quite impressive, the breadth of different things that have got him interested in. If you could, I can't believe you didn't publish the salmon study, because Todd's one of the best fishermen I've ever met. So how did I meet Todd? So Todd was one of those rare people in my life who I walked up to, or actually made a phone call to, and said, "Hey, would you like to scan a serial killer on your MRI scanner?" And he goes, "Yes." And he's like, "That would be totally fun." So the first guy that came out just came out in his nice orange jumpsuit with a couple of guards, and we scanned him and studied him for a bit. And then the next one came out under full SWAT team surveillance. They secured the entire corridor in downtown Chicago and fully, brought him out, ran him in there. He's all tied up and everything, and there were fully automatic weapons all around and near the MRI. We had to make sure they de-armed themselves before they went in. And then for the last one, which he thought was more fun, we could even another guy out was even more dangerous. We studied a guy that came down, and these were pretty serious guys. And Todd was like, "Oh, and we just got a brand new MRI scanner, so we're going to put him as the first person in there, this other spree killer we studied." And so we've been doing a number of these cases together, enjoying definitely makes for a very different weekend morning when the SWAT team shows up at the advanced teams to come out and do those cases. So I try to keep Todd entertained with those things. But in actuality, Todd is one of those rare physicists who has that personality that everybody wants to work with, and he's very fun and easygoing. But he also has a talent. He was able to implement all of our algorithms, all of our things that we do on the scanner in like 10 minutes. And I don't think I've ever gone anywhere where, we've been able to have those things done. So he knows these systems inside and out, and he has been basically, from all accounts, one of the most pleasurable guys to work with, and he certainly is fun to golf with, if you ever have the pleasure. But without further ado, it's my great pleasure to introduce ToddParish and his talk today, Translating Functional MRI Towards a Robust Clinical Tool. So please give me a warm welcome.
Alrighty, thank you very much. That's a good introduction. I guess one of the key points you missed is I was working at Siemens and then I retired for a year, which I thought was pretty enjoyable. I went around windsurfing for a year, and then I went back to I went to graduate school and got my PhD. So I'm going to talk about something that's of interest to me is cerebrovascular disease and blood flow and how it affects functional imaging. So, and mainly because I work in radiology. We have a big practice downtown, and that's where we see a lot of these kind of interesting cases. So I know everybody's an expert here, but I have to show functional imaging in a single slide, functional imaging 101. So right now we have our normal blood flow, so we have arterial arteries and arterioles and capillaries, and it's slightly deoxygenating there. But if somebody yells out ball or snake, then or you get some sort of stimulus, and then you get this increase in blood flow, oxygenated blood flow, that pushes through the whole vascular system and creates this bold signal that we look at. And you can come up with designs to create these functional maps. And so this is sort of the simplest design where you're looking at two different conditions and you can create your statistical map. So the big link here is trying to use this in a clinical environment. So we want to take these for clinical assessments, which you guys are certainly doing. Good, that works. And then I work a lot with neurosurgeons and trying to do pre-surgical planning and assessments of those patients. So one of the biggest things is you have this neuronal activity locally, and then there's blood volume, blood flow changes, and oxygen metabolism that's supporting that activity, and all of that goes into the recipe for BOLD. But we don't really know why, specifically, how this is signaled. So we have this neuronal activity, there's some sort of metabolism, we have the capillary here, and you get this increase in blood flow, but the signals have to go upstream to then dilate and create these responses. And just to put it in perspective, these are little red blood cells in a capillary. So these are the changes, these are what we're looking at with our BOLD signal. So as I said, it's made up of, BOLD is made up of blood flow, hematocrit, so that's the density or the amount of these red blood cells that are there. And some of these things are not within our control. And some of these we can control. So field strength, imaging, the different types of sequences we're going to use, and the paradigms and that sort of thing are all under our control, and then we can use that to take advantage of this BOLD signal. So I'm pretty simple. I like really simple experiments and try to interrogate what's going on physiologically. So I use this visually cued bilateral motor task. So it requires the person to actually respond. And what we do is we have just 2 seconds of stimulation, very brief, and then we have 28 seconds of rest where they do nothing. So we're looking at sort of this impulse response of the vasculature to this stimulus. So they have to move their hands, they just open and close as quickly as they can for 2 seconds. And we train them to make sure that they don't move their heads as they're doing that. And it's pretty robust. This takes just 10 trials we can average over and get a fairly good response of the hemodynamics. And this is actually real data from an individual, but you can see that the stimulus here for 2 seconds, we have this, the initial dips or the oxygen metabolism here going on, and then the blood flow increase that we're typically seeing, and then this post-stimulus undershoot. And so this is this 30-second interval that this blood flow response occurs over. And this is a normal person. So I mentioned I was interested in cerebrovascular disease. So this is a GAD-enhanced MRA of an individual that has a right carotid stenosis here, and then there's the internal, external carotids, and they go up through the brain. And you can see on the normal side how thick and patent these vessels are, and how large the vasculature is here. This is all circle of Willis in here, and how you don't see all these little branches downstream. I don't know if you guys can see that, but it's there. There's a big difference. So what happens is there's alterations in flow on this side. Autoregulation, so that compensates to keep the tissue alive, is also affected, and there's potential for developing collateral flow through that circle of Willis to help support the hemisphere that is underperfused. So if we look at the same person with this technique where we can map the HRF, we can see that you get normal motor cortex and some supplementary motor areas here, but then in the affected hemisphere on the right side, we don't see any activations or signal changes that pass any sort of normal threshold. But if we look at those time courses, so this is now, we're using a TR of 0.5, so half a second, so this is really 30 seconds long. The red is the left hemisphere, the left carotid. Well, this is in the motor cortex, but this is on the left side. And then the green is the response function that we get out of that individual. And so it's blunted and it's shifted in time, and it just doesn't have the same rise and width to that. And if you'll notice, as we go through this, you'll see that it changes in the post-stimulus as well. So that was 1 month after the guy presented in ER. He was a metal worker and didn't have any real insurance, and so he didn't get any treatment, and came back 6 months later to see the neurosurgeon. And so we did the scan again on him just to get I'm sure they're doing it just to get a free MR, but we were able to get good data. And he actually had motor, he was able to utilize both his left and his right hand. So now you can see how the green and the blue have shifted a little bit, and I'm just using the red, the normal hemisphere, as a reference. And then 1 year later after follow-up, this normalized back to what seemed to be normal blood flow for this guy.
So what was the intervention time?
They didn't do anything.
Oh.
He just waited. And so they don't actually know, like he might have reopened up that vessel or developed some collateral flow, at least to give him some autoregulation to be able to dilate.
Did he have cholesterol issues or anything?
I don't know that. He was looked like a normal, healthy guy, but I think he had drinking issues. So. Okay, so then how does that look in these maps? If we look at that same task, you can just see that there's really no changes, and then eventually we're able to measure these changes. Now that's using an event-related, or that impulse response function. If you do a block design, there's really no effects of that because you have that large plateau. They're doing their bilateral movement for 20 to 25 seconds, and then it decays away. So we have a much better ability to detect that. But what's interesting is from the 6 to the 12-month period, you can see how much larger this area is. So you're even still gaining better detection as that normalizes. Then I have another case where this is a person who has an AVM. So this is arterial venous malformation. So arterial blood is shunted directly into the venous system. So it's high pressure going into a low pressure system, and they often create a shunt for all this blood flow, and they don't develop it downstream. And so in this case, what they typically do is they'll do these embolizations. So they'll add in what they call glue or just some plastic material inside these feeder vessels to stop that blood flow. So we did this person, they have a fairly large left temporal AVM. So again, this is going to now be in the left hemisphere. And doing the event-related task, you see a little bit of activation, not much. And then even in the block, it's small, but at least in the right spot. So then they went through 2 embolization procedures. So they just try to block off some, a small portion of the vessels. They don't want to change it dramatically to cause any sort of overpressure on that system. And after a couple of these, you can see not much difference in either of these types of experiments. But then after 4 embolizations, we have normalization of the activation in both motor cortices when you do the event-related task. So the surgeons are able to use this as a way, they can look at it with digital subtraction angiography to see what's going on, to give them some sense of the blood flow, that at least it's not shunting all the way through. But this really gives them the reactivity of those vessels and how it's dilating and changing. And that's important to know how that will affect their ability to do these dilations. So just to show you now the time courses of these, this is in the right motor cortex, so this is sort of the normal hemisphere, although this looks a little odd in this case. And that because this is such a large AVM, it could be influencing the normal hemisphere. So these are all over the period of time of the formalizations. It looks okay. And then here, the blue is the initial condition, and then after doing 2 embolizations, and then we have after the 4, you start to see the normal hemodynamic response where you have that large inflow in the post-stimulus tissue.
And tell you, Todd, is there any performance problems, or do they think they're performing the same, or is their finger and visual, are they doing it at the same rate and stuff, or were there symptoms of the AVM?
In this person, they actually had language issues because this was in their motor or language cortex, but there was no motor symptoms at all. It was not really affecting their day-to-day sort of activation, but when you start to stress it and you look, you can see that. So there's a finite amount of blood to go around, so you wonder what other tissues are not getting or receiving that sort of blood flow. So along those lines, we then started to look at language areas. And we had to modify this task, so instead of just doing 10 trials of this, we ended up having to do 50, 51, although we've reduced that down now to about 30. So that's still, this is taking much longer time, so this is about 15 minutes. This particular data is from 25 minutes of collecting this, so they'll see a word and they have to make a decision if it's a real word or not. And these are in normal people, and we tend to get these standard curves both in the left and the right hemisphere because you're sort of very low level language task. Then we're looking at a number of stroke subjects that have aphasia. So this is the normal right hemisphere, and then this is a stroke subject in the right hemisphere. And these are somewhat delayed even already in the non-affected hemisphere. But then when we go and look at this person's lesion, which is huge, we really see these delays. Now these windows here are out to 12 seconds. And so we can get a fairly big delay from this, from the effect of the stroke. So there's tissue that has been damaged, and there's vasculature that's been affected by this. And so when we do our standard SPM analysis of the data, we don't see any activations with our standard language tasks. But when you start to use and incorporate these hemodynamic responses, you can actually generate and get reasonable responses. So you have to account for the delays in time. So that's one of the key points, is really using the individual's HRF to try to get the best data analysis that you can and create the most realistic map of what's going on inside of that person's brain. So this is important to monitor these blood flow issues when you're having longitudinal assessments of stroke or of stroke in general, or of patients. So we're doing a lot of therapy trials, so you want to make sure that the vasculature is not changing, and that's what's affecting your response. You want to be able to make sure that you're getting true neuronal changes. And then doing aging studies, and also it's really important for these pre-surgical planning cases to make sure you're providing the surgeon with reliable data around these lesions. And this could be from the AVMs or around tumors as well. So I just show, this is another large AVM case where this is in the near the occipital cortex. So they're again doing the same bilateral task, and we have large activations in the unaffected hemisphere. But we don't see any changes in this region of tissue around here, even though the person's able to see these and certainly activating, and they don't have any super visual problems. They did have, because of the small bleed, we're having issues. So I wanted to switch a little bit and just sort of look at what's going on here and how can we probe these people's brains and their physiology to see, to better understand that. So normally, so this is just a representation of what happens in the bullet response. You have your stimulus and you're able to generate that blood flow increase. But in somebody with cerebrovascular disease, there may be a lower ceiling in the ability to generate these bold responses. They can't activate, fully dilate to the same levels as a normal individual. And so what we're trying to propose is to use this cerebrovascular response as a way to use for quality control in all of our subjects, especially the clinical cases, but for all subjects, to see where bullet signal changes can take place. And it's reasonably fast, and it seems to be reliable and doable by, we have a super aging study of people that are over 80, all the way down to children that we're now enrolling that are 8 years old. So one of the ways to do this is to create a vascular challenge. And you can use increased levels of CO2, either through breath holding or using a CO2 enriched air where they would breathe. It would increase the CO2 levels in the blood, which then the brain responds to by increasing blood flow. Or there's acetazolamide, this Dimox that you can inject, and it's short acting, so as soon as it wears off, the person is back to normal. But then you need to have an injection, you need a nurse, they need to be monitored for a while. So there's a lot of complications, at least in a research setting like this, and in our center, where we don't have that kind of staffing. But in the hospital, we do some of these Dymox challenges with some perfusion measurements. So we're trying to increase the perfusion in the brain, and we want to look at the overall changes in the bold signal related to that. So in normal people, if we have this, again, the bold response, and then you can increase the baseline level of signal by CO2, then you have this vascular challenge. Now, the group at Stanford showed that independent of the baseline of this in normal people, this bold activation change is similar. So the ability to dilate further, even on this elevated scale, we have that capability in normal vasculature. But what I'm interested in is this ability to detect changes from the normal baseline to an elevated baseline with CO2. And so we developed this task where it's a breath holding paradigm where we have some time initially just to get a baseline signal. We cause the person to breathe in and breathe out. We give them auditory cues and visual cues to breathe in and breathe out 3 different times, so we're controlling their breathing. It actually tends to hyperventilate them a little bit, which is actually good. That drives our signal lower. And then we have them hold for just 15 seconds. They hold the breath for 15 seconds at a time. And then they get to free breathe after that for 21 seconds. So this particular part of it is repeated 6 different times to generate our changes. And so here, what you're looking at is the areas of the brain that we're able to modulate just due to breath holding. So it should be limited to mainly the gray matter where we're seeing these changes. And then it's just a slightly different view, and it just shows how significant, how clean the signal is, if you can see the little red lines, but there's a fairly large signal change related to that. So now what happens in cerebrovascular disease, we do these dilators. So we have this, normal people have this elevated baseline level, and they can generate a standard bold response. We have now, in this side over here, is where people have some mild level of cerebrovascular disease, and they again have this ceiling effect of this bold response. But it could be that at these elevated levels, that bold response may be very small. They may not have the reserve capacity that we do as normals. And in a worst case, they may not have any ability at all to change these baseline blood flow when you're at that challenge. So that's what we're trying to see, is where these regions exist and how does that impact our interpretation of whatever functional or bold data that we're getting. Yeah. So this is a person who has a fairly large tumor here, and this is our standard clinical synonym task. So they have to do discrimination between 2 words and whether or not they mean the same thing compared to fake words, and we're trying to activate language areas. This is the left hemisphere, and you can see the compression effects of this lesion, but we don't get any response in areas that we would expect. We also had this person do a motor task, and we weren't getting any responses in her motor areas, although she was completely with it. She was speaking, able to do the task, had nearly 100% accuracy on this, and was following the motor portions of the task. So when we did our CVR study, so that's the cerebrovascular response, this is her holding her breath, and you can see that there's very little activation or changes in blood flow in either hemisphere related to this. And so this is a person, if anybody can identify those are essentially little lifesavers that are MR visible. This person's going to surgery, and they use this for the stereotactic planning. So they really needed this information, but we weren't able to provide anything for the neurosurgeon on this. He went in, and so he was concerned about this, and we recommended that they do an awake mapping study. So they had this person awake in the operating room, and was unable to find any areas of language activation in this person either. But so they just drained whatever this was and did as little as they could and waited for her to recover. So it's not clear why this was going on, if this was impacting that or what medications this person might have been on prior to getting scanned by us, but it also didn't help that they were unable to do the awake mapping and get any reasonable results there, although those are often difficult as well. So then in another case we had somebody with this, it was a resected, but there's a little bit of change here, a tumor, this glioblastoma. And so I'm showing here, this is a fairly low level activation map. And so all these things are actually processed on the Siemens scanner, which does all this stuff inline, and you can do it afterwards as well. But for our clinical cases, we use this software. And so it has the positive in red and negative in green. And this is a hand movement. He was just trying to move his wrist because he really didn't have finger movement. And we'd expect an activation around in here, but we do get good supplementary motor activation. You can see a fair amount of that here. When he did the other hemisphere, these guys lit up very nicely. When we also were doing a tongue task, so they would move their tongue behind their teeth, and you can see strong activations here very nicely, and it's typically bilateral tongue control. And we didn't get that around that tissue that we suspected would be responsible for that. So then we did the CVR, and we can see that we get a fair amount of activation or change here. So we should have been able to see a response if that was actually, if this tissue was still involved in that kind of function. And then the tongue area, this tissue didn't have any changes there. It actually looks changed because of infiltration of the tumor. So it's not surprising that this didn't give us any activation in the tumor side. But it was nice to know that we were able to potentially see that. And you can see the SMA areas have a fairly strong signal change there, so that you can believe or understand that bulb response is actually real. And then this was that large AVM that I showed before. So back here, we're just curious what's going on. And we did the CVR study on this. And in this case, this AVM is shunting blood away from tissue that's around it. So when they're holding their breath, all the additional blood flow goes out to the cortex, where this tissue then is, the bulb signal is actually going down when we expect it to go up. And this is often can be a problem in these kind of large AVMs and around some tumors even, that you would get this. And so you have to be careful how you deal with these AVMs. You don't want to shut them off quickly and then hyperperfuse tissue around that. So now, going the other way, instead of doing vasodilation, you can do vasoconstriction. So again, we have our normal people here with our normal bulb response, and then we had been administering caffeine, and what happens there is it's a vasoconstrictor in the brain, and you get some decrease in blood flow by 20 to 30%. Your baseline blood flow just goes down, and yet you get similar bulb responses, or we're actually demonstrating larger bulb responses because of this, potentially this lower baseline, and the higher recruitment of the neuroexcitability of the caffeine itself. So this is something that we've seen, and some other groups have shown this, and some have shown no increase, but just a same level of bulb response. So to give you an idea what that looks like, here is just as pre-caffeine. We do an IV injection, so it's like pulling up to the Starbucks drive-through, and then we can inject 2.5. We do a couple different doses, but 2.5 milligrams per kilogram seems to be the best. So that's like a cup and a half, 2 cups of coffee. And at the same statistical levels, we see these larger spatial extent and also amplitude changes related to the same task. And just to look at that on these response curves, these are the 3 different regions. We're looking at left and right motor and primary visual. This is all before, and then you can see these changes afterwards. And really, Tom Liu in San Diego has shown and done some analysis that these rise times, these curves tend to shift closer, like you have a much quicker response. The vasculature it's constricted, but it's sort of like Kent's snake is coiled up and ready to respond with a larger response dilation-wise when it's challenged. So just to look at that, you have your normal, this is in the resting condition, this is a cross-section of a vessel, and then you have some small expansion to create that bold response. But after you have caffeine, the vessels actually shrink down and you get sort of concentrated deoxygenated blood, and your bold signal decreases overall. The bold resting bold signal goes down, and then you have this expansion from this condition out to what is normally the level of dilation in the vessel, or it can even go larger because of this coiled spring effect or increased tone, and so you get this larger blood flow response. We then also have used some calibrated bold experiments where you're changing the levels of CO2. So here we're doing CO2 breathing. You can change the gradation of level of CO2 and also the task itself. So there we paced people at 1, 2, and 4 hertz, and we had different levels of CO2 breathing. And you can calculate the oxygen metabolism and how it changes with blood flow. So we used a combined it's an ASL sequence, and we looked at the early echo for the perfusion signal, and then we had a bold signal at a later echo, and we're able to create these maps. And what this is really showing is, this is in the motor cortex and this is in the visual cortex, but the darker is the pre-caffeine, and then there's a slight shift, not really a change in slope, but really just a shift, well, a little change in slope of these curves. And so for the same level of oxygenation, the metabolism, it requires less blood flow here. So you become more efficient when you have this caffeine. And so you can see that both in the motor and the visual cortex. So we're able to look at the metabolic effects of caffeine as well. And I'd be remiss if I didn't show resting state here of the effects of caffeine in resting state. So this is in seed-based analysis of resting state. And so we did essentially the same experiment. We had them in there, injected them, and did it again. Afterwards, this is, I think, 13 subjects or so with a C in the left hemisphere. And so we get some map of that motor connection. And then after caffeine, we see a decrease in the cross-hemisphere connectivity or synchrony with that bold signal. And so there is this decreased blood flow, and so there may be less artifactual signal or physiologic signal that's also involved in the bold signal that can then alter our resting state analysis of that data. And again, Tom at San Diego has also shown similar results in motor cortex. We also did the default mode and showed more or less the key players were still there in the default mode, but the spatial extent of those regions were much less in that analysis. So I just think it's important to think of the status of the cerebrovascular vasculature when it's you're investigating bold-based or flow-based signals in the brain, and that is in particular if you're looking with people with already existing abnormalities or in populations that may obtain these or acquire them over time or have their vasculature change with age. There's also control for medications, caffeine, nicotine, these things that affect the response of the vasculature. And I think that one of the issues is this bold signal sensitive to potentially the compliance of the vessels throughout the brain, and that changes as you have these other chemicals, or as mentioned back there about well, you asked about the patient. I'm blanking his cholesterol.
If he changed his diet,
Yeah.
that's why it came.
Yeah.
That's what I was curious.
Right, so these issues that affect the vasculature as well. So I think collecting this kind of information is relatively quick and can be done either through a challenge, or there are groups that are proposing to do sort of T2 venous measurements to try to assess the baseline oxygenation level of the blood, but that really is looking at the resting condition of that, and you really need to look at a challenge to be able to see what differences you can have when you're doing these tasks, activation tasks. And again, it's important for these longitudinal studies when you're doing them, trying to compare and look for therapy effects or treatment effects over time. So I think I'll end there so we can have a good discussion of this, and I just wanted to just show, this was the super SWAT team that were all geared up, and this is the reward. McDonald's, this should be an ad, really, for the McDonald's to support them. So, all right, so I'll take some questions.
So, Todd, do you think that the latency, it seems like a lot of the vasculature differences are latency-related effects, either like the sluggishness or slowness to respond, but and also the gain effects. But
Yeah.
do you think latency-insensitive methods would be? I mean, what you've done is you've identified there's a latency effect, and I think that's probably the most important thing. But you could certainly repopulate your maps with latency-adjusted hemodynamic responses, just a different model, and it might look more normal. So I guess always the question that we struggle with is, if you have a normal behavior, that is, they can do the behavior just fine, but the hemodynamics is different, should you use a model-free kind of procedure, if you will, to analyze that, or might that just miss the pathology that you're exactly trying to see, how it changes? And I'm also, you have to be very sensitive, especially when we're in psychiatric groups, just like, I guess, clinical patients. You want to do tasks that they can do. Because if they can't do the task, then it's not going to surprise you don't see any hemodynamics. And so how do you walk that balance? Or are you using basically the shape to just help make inferences then about exactly what's happening?
Right, so the shape, and I think you're right, there's either a latency or this amplitude effect. And so you could account for some of the latency issues with these model-free methods. But if you have reduced amplitude, the ability to generate that response, then you're going to just need that many more data points or not be able to be sensitive to it at all.
Sure.
So yeah.
And have you, has anyone looked at the fact that, because like ICA would be potentially this alternative way of assessing, for example, resting state, is it just as sensitive to caffeine, for example, or is it more, because if you do a C-based kind of thing and you've got a shift in latency between different regions, C-based isn't going to capture it as accurately as perhaps a latency-insensitive method might capture.
That was actually in normal people, so I don't know that there would be any latency.
But with or without caffeine, though.
Yeah.
So my question is, I guess caffeine's going to make a difference, but if we use a method that accounts for that difference, is that sufficient? That's what I was wondering. Because obviously we typically scan all of our subjects, at least in my lab, where they come in like they do normally. So we don't tell them don't do any caffeine, because this morning we would not have been, we would not have functioned the same. This morning we hadn't had some espresso. So the question is, what do you recommend based on those work? Do you suggest people they come in and record it, make sure you know what they have, or do you just have them and have patients come in, or do you try to do withdrawal?
No. Yeah, so we don't do withdrawal. We do try to get people at their normal, just have them come in at, if it's longitudinal at the same time, have them try to do the same sort of diet. And don't drink too much the night before, and just have the same sort of behavioral. Not everybody abides by that, but.
Vince?
So when you see individual differences in the hemodynamic response subject to subject, they're there, you look at them, scratch your head. You seem to be suggesting a lot of that might point to a lot of perhaps hidden vascular problems in the normal population. But how much? Do you have a guess? I mean, you're looking at this pretty intently.
Yeah.
There could be gene differences relating to neurochemistry, whatever. There could be a long list, and that's just part of the list. But do you have a sense yet about how predictive this is, or what portion of variability this accounts for, or anything like that?
So the variability in normals is not that much.
Well, I've seen it.
Yeah.
I mean, it depends what you do. In an oddball task, looking at target response in selected brain regions, it's pretty pronounced. I was surprised. You know, I published this 12 years ago now, and they made me, put it in the paper. I couldn't explain it. And
Yeah, I guess mainly we've been looking at these sort of very affected systems where they have a lesion of some sort or a stroke or it's very disrupted. So that sort of makes sense. But in these normals, we have not tried to associate it with sort of a gene or some other biomechanical sense.
so you're just not sure
Yeah.
to what degree that might be the case. Okay. So,
Well, then to the same hand, we published a study of 100 subjects with oddball, and what was the most amazing about it was when you did the latency adjusted HRF using the driver boost procedure, it's amazingly reproducible in the regions.
yeah, but you're accounting for this variability that way,
Yeah.
right? So,
Right, but I don't know that it's necessary. Yes, I mean, I think that there's small variance that occurs between individuals, not nearly as large as what Todd was saying, shifted that many seconds, but a second or so here or there, that's a reasonable thing I think that you would expect individual differences would show. It may be related to all of those variables that you were suggesting. Many of them might be of interest, genetics, stress, anything that they may be perceived, et cetera. So, but that's basically, I think, what I find interesting is those individual differences. I mean,
yeah.
he's very different than other people,
Yeah.
and hemodynamics are very different. So,
Yeah, but stress, that's a good point, because we had a number of these subjects come in for our treatment studies, and we end up doing essentially an imaging session ahead of time that we don't really even use. I mean, we use it as quality control and look to see for these differences. But a number of the patients had said that they didn't feel like they did very well because they were stressed out when they were in there. And so these are aphasic patients that are being forced to do these language-intensive tasks that they know they're not very comfortable with doing those. But then the second session, they improve on their accuracies, and the maps and the blood flow responses are much better.
good. Other questions? Yeah, Jeff.
So Todd, when you get one of these cases where the vascular compliance is just very poor for the challenge test, do you think there's going to be a way that you can correct for that, or just ball game over, don't bother with those subjects?
Well, it depends on what the reason. So if there's a small temporal shift, then you might be able to, then you can account for that stuff. But if you're really not getting the amplitudes, the responses there, then there's something wrong with that coupling, and you really need to, go work with the physician and see what's going on there, and can you modify it. So we've had to bring back people multiple times because they've self-sedated themselves beforehand, and that doesn't help. And so it's important to try to be able to get them. And then otherwise, just let the surgeon or the treating physician know that they aren't able to get information. They need to find an alternative method for these clinical cases.
Yeah, we talked about couplings in patients with impairment. So there's no cases in particular high-grade tumors that the coupling actually breaks down, which then leads to a possible situation where we may not be able to measure brain activation with the same sensitivity as we do in healthy controls. And so what to do about that, which wouldn't show up with, not necessarily show up in the calibration experiments. Providing them quantitative metric of the activity, or maybe guiding the surgeon to say this is not active. Can we do that?
Yeah, so we try not to speculate on what's not active. So we try to get them to assume that everything is involved, and the areas that we can identify with our tasks are what we really know about around those lesions. But I'm not sure if that answered that part. I mean, so even with those AVM cases where we have those regions where there's that vascular steal, we can sometimes get activation around there, and just reviewing that data, making sure we're put on alert because we have those vascular maps that tell us that that's disrupted, that we can go back to that functional data and look at it and make sure that they're responding properly in those regions. And we'll believe those, but if we see no activation around there, then you have to assume that these are either low-level neuronal signals, or the bulb is the coupling so distorted that we can't get that measurement.
Todd, do you have any feeling just across patient populations, but not ones with obvious vascular issues? So the schizophrenic subjects show the same level of vascular autoregulation, autistic kids.
No, I haven't done that. I don't know, schizophrenics, I don't deal with them that much at our institution, but there's some high influence of nicotine and those things, so that may be something that could be distorting. Autism, I don't know.
But I think a lot of the antipsychotics can also have vascular problems, vascular issues, and so it is a landscape. If you want, it depends on what you're trying to do clinically. If you're trying to develop some sort of improved diagnostic procedure or improved psychiatric assessment procedure, but using imaging, those things are part of the landscape. You have to have a method that's robust to them, hopefully. And if BOLD isn't robust to them, or doesn't give you the same characteristics, you need to be using either something else on top of it, or not using BOLD, especially if that variability is going to confound the potential diagnostic. Very important things to look at. Not very fundable, by the way. I mean, it's hard to get money to do the type of studies to develop a diagnostic test. I mean, that's probably more the SBIR mechanism things we've been talking about, rather than the little pedantic things that you need to do to have a FDA-approved diagnostic procedure. You don't often find study section thinking that that's really interesting. Yeah, it's fun.
Back to the caffeine studies, I'm wondering what the value of caffeine as a drug is, since it has two actions. It constricts the vasculature, which of course changes the impulse response function. That's consistent with hyperventilation experiments where you see the same acceleration of the movement response. But the amplitude response is something that's a little bit difficult to interpret, since caffeine also excites the neurons to some extent. And so you have two actions at the same time. And people are differently sensitive to this. We've done experiments where we had given them, not intravenously, but a cappuccino, and a whole shot, or quarter of a shot, and it had a pretty strong kind of impression on them, but the BOLD effect didn't show much of a change, which really surprised us. And so we were thinking at the time that there were two mechanisms. The constriction reduces the BOLD effect, but then the neuronal excitation increases, and so they balance, and thereby you don't see much of an effect. I think that depending on how you administer it, intravenously might be a better way to do it. It's just, is that a practical thing to do? I would say.
Yeah, I do it at home.
IV? Yeah. No, that's a very good point. So one of the other effects of caffeine is this neuronal excitability. So we have, I didn't put it in here, but I have done a little study on using navigated TMS to try to look at motor evoked potentials before and after caffeine. So we have this, it's just like they use in the operating room, and it's an infrared guided system, so you can stimulate right over motor cortex. You know exactly where that is. And what we showed, we mapped out using different levels of stimulation from the motor threshold going up, and you can see these responses, and we had a huge increase in that motor evoked potential after giving caffeine, again through IV, but it clearly is there. I think you're right, and I don't know if the blood flow changes is enough to account for that bold increase that we've been seeing, and I think the increase in neuronal firing might be one of those ways to account for it. So we're trying to look at that, and maybe MEG is another way to try to do it.
So Todd, what's the next bold technique? What do you think will be the next big thing in human imaging of cognition? Some other measure of cognition?
There's a crazy guy at our place, Tom Mead, who's a big chemistry guy, and so I think these new contrast agents that may be sensitive to different environments. So he's looking at calcium channel sort of activators that'll give you those signals that'll be really closer to the neuronal firing and BMR sensitive, that sort of thing. So I think nanoparticles has got to be involved somehow too, but I think some sort of new activation agents.
How do you administer those agents?
Well, right now they're Petri dishes and rats and.
Or how would you have to get into the CSF?
Yeah, that's where they get them now. They'll inject them into the CSF and let them leach in. Yeah. So, yeah, it makes the caffeine look much more practical.
Yeah.
Going once, going twice. Well, Todd's around today, and this afternoon if people have other questions they'd like to ask. Otherwise, let's thank him once more.